Welcome everyone to one more webinar for the National Dental Practice-Based Research Network. Today we are going to be listening from practitioners and the principal investigator and our director of the network about the periodontal adjunctive antibiotic study, best practice, and we will be talking about sharing your experience doing this study. We will start with a brief update about the study, and then we will go on to discuss best practice in this study. To introduce the study, we have the principal investigator, Georges Kotsakis. He's a professor at the Rutgers, and then Dr. Gilbert, the network director and a professor at the UAB. We also have here someone that you are already very familiar, which is our node coordinators. From the South Central region, Alina Potluri. From the Southwest region, Ashley Spencer. And from the Western region, Sweta Matur and Kristi Kathleen. By now, if you are a practitioner in one of those regions, you are very familiar with them because they supported you in your training for this study. And we are also joined by practitioners this time so that they can share their experience on this study. From New Orleans, we have from Dr. Kristi Soileau. She is a periodontist, and she's joined by Huong Dang and Megan Cantore. From Phenix City, Alabama, at the Riverchase Dental Care, we have Dr. Obebe and the dental hygienist, Emily Sheldon. Those are from our region, the South Central region. And from the Southwestern region, we have Dr. Alonge in Houston, Texas, and Dr. Kotha from Blunt Creek Family Dentistry in Austin, Texas, as well. We will now hear from the principal investigator, Dr. Kotsakis.
Hello, thank you for the introduction. Appreciate it and appreciate everybody doing here. Before I start with the slides, I just want to say a big thank you because we really have all of you, our collaborators, being here and helping us move forward with the study. We do really appreciate what you do in practice, and we're very glad to see that we can get some data from realistic clinical situations. So, as you all know, our main study goal here is to evaluate the effectiveness of scaling root planning, the standard form of non-surgical periodontal treatment, plus adjunctive antibiotics, as compared to scaling root planning with placebo. And we have 3 time points in our study: the baseline examination right prior to treatment. Then we have the early follow-up at 6 weeks, early assessment of scaling root planning outcomes. And then we have the 12-month, which is the study endpoint, where we're assessing final treatment outcomes. It's a major goal, really, to get to 544 patients to finally have some definitive data on whether antibiotics have an effect in non-surgical periodontal treatment or not, and to have appropriate power to say, well, maybe they do in some subgroups in what we call subgroup analysis. So to do that, we have a recruitment goal of 37 practitioners from 3 network regions, the Western region, the Southwestern, and the South Central regions. And we're looking for each practitioner to recruit about 16 patients or up to a maximum of 22 if they have the capacity. So as you see here, for the time being, our practitioner recruitment has been completed. We have 10 practitioners in the Western region enrolled and study ready in our study, 13 in the Southwestern region, and 14 in the South Central region. So thank you all for going through all the hoops that are required to be research ready, and most of you for recruiting your first patients. Now, as you can all appreciate here, we haven't been tracking to our recruitment goals yet. At this point, we have a little bit over 75 practitioners. At the time the slide was created, we had, patient participants. We had 75 patient participants out of our goal of 544. So we're a little bit over 10% recruitment here. So a long way to go. And you can see that there are certain disparities here with 16 patient participants enrolled in the Western region, 21 in the Southwestern, and 51 in the South Central region. So the main reason why we're coming here together is to share lessons learned and share experiences about what can make recruitment most effective, efficient, and definitely not burdensome for the practitioner, how we can most easily integrate. So I'm very excited here to learn what works best in your practices and to work collaboratively with you. Thank you very much. I think for the next slide, I'm going to pass the baton to Dr. Gilbert to talk about lessons learned. Thank you.
Thank you, George. So we're going to move on to the lessons learned section. So for all of our clinical studies, we end up learning not only answers to important clinical questions, we, from each study, learn just a little bit more about how best to do clinical studies in busy practices. So the PAAS study has been no exception. And so that's a key focus of today's webinar. And so I'm going to break down these lessons learned into these categories, these 6 categories. And we garnered these lessons learned from practitioners and no coordinators. And I'm going to go through each of these categories. And I think maybe on this slide, maybe all of the lessons learned from this slide may have come from Dr. Soileau's office. I'm not sure. But she and her practice have been a leader on this study so far, so we're very grateful for that. So regarding patient schedule review, it's been very productive so far for the practices that have been at the forefront of recruiting a lot of patients. For the office staff to review the upcoming clinical schedule for patients who are getting or scheduled for scaling and root planing. And while they are doing that, it's also helpful for the office receptionist or whoever's doing the call or contact to be looking at the eligibility criteria. And then we do have a flyer set aside for that. And then I think the note coordinator would have given you that. We have at the very last slide of this whole slide set, a PDF file of that so you can look at it again to make sure this is something you have, because what we've learned is that if the person calling up the patient not only verifies that they are getting scaling and root planing, but they meet these other eligibility criteria, then you're quite ahead of the game in making things more efficient. Patient list creation. So the patients who are scheduled for SRP or have been identified, and then going through this list to see if that particular patient would be eligible before they come in the office. So in addition to finding out before they even set foot in the office whether they're eligible or potentially eligible, it provides an opportunity to explain the study to the patient in a broad brush to see if this is something they'd be interested in. Right? Some practices, in addition to doing that, have taken the next step of either of emailing or, I guess, potentially postal mailing if possible, sending them a copy of the study flyer, and this gives them time to read and prepare any questions, potentially the informed consent form as well. Because this is a randomized clinical trial, the informed consent form that I think you've all seen by now is pretty long, and it's detailed because it has to be. And some of it involves some legal language, and so practices have found it helpful if the patient can get that before they even show up at the office. It gives them an opportunity to read through that, and after reading through it, well, okay, this is not so scary. I can take leisurely time to read this legal language for the paragraph or two that has that in it, as well as explain the study, so that by the time they come into the office, they're pretty clear on that, and they can ask you any questions in an efficient manner without having to take a long time to review all that. So in addition to setting up time for the treatment, practices have told us that it's helpful for staff to allocate time or come in with an expectation that they'll need to spend a little time addressing the questions before starting the official screening process. That either has to do with eligibility or the informed consent form. So once the patient's been confirmed eligible, proceed with the enrollment process. Now, one thing in this study, which is now most of our studies, but we have some multi-language studies. This one we cannot. It really needs to be English speakers only. That's because the informed consent form is in English. And our institutional review board only allows English speakers in this case, because that's what the informed consent is in. We have some additional categories regarding medication dispensing. Let's go to the next slide. Okay. So this study has some interesting abbreviations, a lot of I's and a lot of P's. So IPP, IPSP, PID, PPTID. Okay, so you've run into those already. Hopefully you've worked through that. There were some initial instances where people really had to get up to speed on that. So you get this box in your practice, the individual practitioner startup package, and inside that box are quite a few IPPs, individual participant package. And then there's the PID, which is the practitioner ID, and the patient participant ID. And then when you log into the hub to enroll the patient, you're asked to enter your practitioner ID and the IPP, and that's the individual participant package. So that relates you and a patient to a particular medication, because remember, half will get the antibiotics and half will get the placebo. We also had to clarify early on with patients whether or not to take the medications with food. The advice is to take it with food. Next slide. Because practices do not all have the same electronic dental record, we're trying to make it easy on you. You can use whatever electronic dental record you want to use and routinely use. Now, the flip side of that coin is we need you to send an image or screenshot, usually, of whatever electronic dental record that you have. And so when you send that image into the hub, it's important to avoid any cutoffs on that, so that Dr. Kosakis and team can see the full image that you're sending. And some of you may have screenshots that only have the pocket depth. Well, we really need the screenshots that have that, plus the bleeding on probing, plus the gingival recession, because all those are measures in the study and important clinical endpoints. And that needs to be included in the image that you send. Another thing that's a lesson learned is uploading this image is what triggers the patient payment. So that gets the patient fully entered into the system and then prompts the system to send a patient payment request. We have had some 6-week reevals already. So that's a good time to remind beforehand to remind your patient to return the medication in the bottle. Remember, we would like them to show up for their 6-week reeval visit with that in hand so that you can verify how many pills they've taken. Next slide. 12-month visit, we've not had any of those yet. Just for future reference, when you have the patient come in, they can be scheduled as early as 10 months if that's more convenient for you and your patient. Next slide. Okay, as I mentioned, a lot of those came from Dr. Soileau's office and her team, so we're very grateful for that. And so now she and her team will provide some, what do you call it, color commentary or maybe more detail. And so I'll turn it over to you, Dr. Soileau.
All right, thank you so much, Dr. Gilbert. Am I audible?
Yes.
Okay, very good. So I want to first off, thank you all for this. And I'm very familiar with Dr. Kosakis. He's got a very good name in the periodontal community. So I'm very pleased to see I was pleased when I saw his name coming through with the study as an affiliate and actually as an organizer and initiator. I want to also thank my staff. The ladies that are working with me on this have done other research projects, but this to me is probably the biggest thing we've tried to tackle. You have to be organized and you have to be certainly interested in doing it and interested in loving science. So I have to give credibility to Huong and Megan. I also have to give credibility to my dental hygienist and anyone else who works with her, because what happens is after Huong gets everybody, all the patients organized on the phone, then when they come in, even though they've been prompted and preempted and educated and given time to think about it, so this is not cold water in the face and walk in the door, we have a study, would you like me to tell you about it? That's already taken care of 10 minutes of Q&A time. So they come in, they've decided for the most part, some are on the fence, but for the most part, they're coming in yes, I'm going to do it, or I'm so sorry, but no, that's not for me. That's fine, but there's no judgment at all. So Hung and Megan have taken turns, and I've taken turns. We'll go in there, but they basically do interview my patients. I have to say, I have not done much chair side with the patients. They've taken care of that for me, and it works well. But the hygienist is put behind about 15 minutes, even with the preempting. So that's just something that you'll have to allot time for if you haven't thought about doing that yet. So Denise is doing other things. So when she comes in, she might be checking one of my post-ops or polishing a post-surgical patient or something like that. There's always something to do, as you all know. So she just has to kind of stay to task, and we limit conversation when she gets in the room so that we can keep the patient and ourselves on time, or we just leave another 15 minutes. So the other thing that I think you might not have thought about, and then I'll turn it over to Huong, but because Huong really she's the one that has kind of gotten the script together and communicated with Megan. They together have gotten this flow going very well. And anyone in here is welcome to call my office. My number is 504-899-2255. 504-899-2255, and they can help you walk through something if you need it with a patient in the chair or whatever. But you want to have, because they're going to need water, and instead of just reaching over and getting water out of the tap, we try to treat them kind of special because they are, listening and trusting us to take good care of them with the study. So we have cold water and we have room temperature. We ask them what they want, and we give them a bottle of unopened, water, spring water. Then we also happen to keep, because of surgeries, we keep food on hand. We have applesauce, and we have protein drinks. So we ask them what they prefer. So if they didn't eat before they came in, many don't, we ask them what they'd like to eat, that we prefer they take the medication with food if they decide to enter the study. So as of that, I think Huong and Megan will take it from here, and if I need to interject, I'll be glad to. But I think they're going to tell you what makes their organization so successful in getting so many patients signed up.
Like I said before, we, if Huong's the one confirming the patient, she'll ask them if they're interested, and it is so helpful if they can get the information beforehand, because then they're not like, oh, I have no idea what this is about. Because some patients will say, oh yes, email it to me, I want to know what it's about, and then they come in and they're like, oh, I forgot to look at the email. So it still, if they did that, it takes so much more time to give them a rundown of basically what it's about.
So basically, when I call to confirm patients, I'm already looking at the periodontal chartings or anything in the past, just to see if they're even candidates, whether or not they have 20 teeth, natural teeth that are not third molars. And also, I do have an idea of what the medical history is, whether or not they have allergies or they're on immunosuppressant medications. So typically, I'll ask the patient straight off, are you allergic to any antibiotics that you know of? And that prompts and lets me know, okay, proceed with telling them about the study. So I'll ask them for their email address. I give them, a little pre-information about what the study is about. And then I say, okay, well, attached to this email is the consent form. It's very, very detailed. Take your time and read it. If you have any questions when you come in, you have plenty of time to ask me. Also, that you don't worry about signing this consent form. If you participate, then when you come in, you will sign it digitally and it will be emailed to you. So the patients have the time to read it. When they come in to their appointment, I'll ask them, did you get a chance to read the email? And they would tell me yes. And if they're interested, then we'll proceed. If they're not, then no big deal. We'll bring you back. We'll see you, for your cleaning. It's not a big issue. But if they do come in and they say they want to be a participant, then I reiterate what was said from the beginning. That way they know that I'm not changing any information. If they have questions, I can answer it. Also, let them know that if they want to withdraw at any time, they can do so. It's not, they're not committed, to a study where they cannot change their mind from. So once all that's done, we are able to sign them up for the study. We do give them the antibiotics ahead of time with a protein drink majority of the time. That way they have something to coat their stomach. And what I did find out along the way is some patients have had a side effect like diarrhea. So I spoke to a pharmacist and they have recommended that if we are prescribing this, we might want to also recommend a probiotic that would help with the patient's gut, or so if they are experiencing any type of side effects such as diarrhea.
Well, and I think some patients are just more predisposed to that anyway. So, taking the probiotic may help.
Thank you so much, Megan and Dr. Soileau, for sharing your experience with this study. We would like to hear now from other practitioners, and they might have some questions also for you. So let's wait and see if we have more questions. But I would like to start with Dr. Obebe and Emily. Can you share something that's worked well in your practice?
Well, I think when we started the program, we were lucky in, not lucky like that, but most of our patients are like new patients. And we were able to talk to them about the study. And most of them were interested. A lot of them are saying, oh, we don't trust any study. So those ones we were not able to enroll in the program. But what worked for us is to be able to talk to them about the study, the benefit of it, especially when they have periodontitis, they kind of willing to listen. Once they find out that, okay, what we are trying to do is to find out whether taking antibiotics might actually be helpful in treating the type of disease that they have. In most cases, they are willing to sign up. And the credit will actually go to Emily, who does all the paperwork, follow-up, and all those things. I just do the exam and make sure they are fit into the criteria. Then we hand them over to Emily to continue to do the paperwork. So all the credits go to Emily, actually.
So Emily, can you share with us a little bit of what you have been doing for being so successful in this study?
Well, we've been so successful. Well, I mean, like you said, we just had a lot of new patients come through with perio issues and have been willing to be a part of this study and just explain to them, you're just taking a round of antibiotics. It's nothing too crazy as far as the study goes. It's pretty simple. And I mean, who can't benefit from a round of antibiotics? I don't know. I like you said, I feel like we've been really lucky to have gotten off to a really great start so far.
How do you do the screening process? Do you do some of the practice that Dr. Soileau's office is doing on looking at the charts before, calling the patients? How is it going in your practice?
Well, majority of them have been new patients, so they come in and sit down with the doctor or myself, and we do evaluate their medical history, do their exam, do probing depths. Pretty much most of it has been done with their initial visit, just kind of in office.
And then next time you schedule the scaling route planning for our next visit.
Right. If I can't do it that day, then yes, we do a follow-up appointment to start the scaling and route planning, and use the iPad and go through all the consents and information with them. Yes, ma'am.
Very interesting to see how each practice is doing and implementing the protocol. Thank you, Emily, for sharing with us, and Dr. Obebe.
Thank you.
Dr. Kotha, would you like to share with us what's your process in your clinic?
Hi, everyone. It's nice to meet you all. And What I'll say is we actually follow something similar to Dr. Soileau's office. We always look at our schedules. And we always talk, I asked my friend as to call the patients ahead, describe the study. And if the patient is interested, we do send the informed consent ahead. And we always tell them, you do not have to sign anything once you come in. That's when, if they are interested, that's when we enroll them in the study. Yes, pretty much it's 95% similar. Only thing is I explain the patient about the study because most of my patients prefer it to be me discussing about the study. One thing I have noticed why we have I have 4 patients enrolled in the study. There were another 5 to 7 patients who were actually eligible, but they did not want to enroll because they were worried about the size of the antibiotics. They felt it was too big. And some others did not want to take antibiotics. Oh, I always explain to them that the chance or the probability of it being the actual antibiotic is 50%, but then it's of course up to the patient if they want to participate or not. And I also explained that it's not a commitment. If they're not willing to do it, that's completely fine not to enroll, because there are certain patients who also said, hey, we will enroll, but we are not sure if we want to continue it. Which I would say, I was like, no, that I would rather say do not participate, that's fine, than withdrawing in between. That would just skew the results and cause more issues. One other feedback by a few patients was they preferred the notifications being sent to for every session of antibiotics to be taken. So let's say if the mornings, the afternoons, and also the night. So every 8 hours, they wanted them us to send a notification for them so that they can take the antibiotics.
Wow, can you do that?
We cannot, but I did send an email to Ashley saying that, hey, you know what, this is what one of the patients was suggesting. Oh,
That's interesting. They want more communication, not
not to, I think it goes both ways. Some patients prefer nothing, some patients prefer more. So, yes, that's our experience in the practice currently.
Thank you, Dr. Kotha, for sharing that with us. That's really helpful for us that are planning the study to hear from you that are implementing it. Dr. Alonge, do you have something to share with us regarding implementing the study in your practice?
I think the antibiotic is an issue, you know, because I had a patient that she only took the first dose. By the time she came back, she brought everything back, you know. That was too big, she couldn't take it. But I have 6 other patients that they have any complaint about it, you know. So, but I think the size is an issue, you know. And then the other thing is, you know, but I don't know, I mean, because that would be part of the protocol of the study, you know, it's one of the reasons it's difficult to recruit patients because the history of previous use of antibiotics, you know, kind of eliminates a lot of people because we know the way antibiotics are being prescribed, especially by physicians, you know. So it's very rare that you're not going to encounter someone who's not taking antibiotics with, you know, recently, you know, especially if they have an oral issue and they present to a physician, they always get antibiotics. I mean, it's from my own experience, you know. I mean, that's my main observation, you know. I mean, for me, recruiting is not really an issue because I talk to patients myself. These are people I've been treating for years, so they listen to me. You know, I've not had anyone refuse to participate. It's just that by the time, like the example I gave, like the antibiotics, I mean, that rules some of them out. Some who have had skin and root planing recently also rules them out, So now then, the other thing is, what do you do about such a patient? I mean, who did not take, because this is a study on antibiotics, the patient only took one dose and returned everything. Does she continue in the study? Because I already did the 6-week follow-up. I just thought, yeah. All right. Thanks.
That's a good point. We do want the participants to take the antibiotics, but when they don't take it, we want them to continue in the study for sure. We will collect the data until the 12 months. So that's a good point that you are bringing.
All right. Thank you.
Thank you for sharing with us. I would like to open now for others to ask questions. And if you feel comfortable, you can unmute yourself and open your screen, or you can put on the chat any questions.
I just want to add it to your for what you said about the patient wanted to get notifications. I do tell my patients that I set alarms for morning, noon, and night. So it's about every 8 hours. So when it goes off, then they know it's time to take their medication. So a lot of patients are doing that.
Emma, would you like to ask a question?
Yeah, actually, I have a question about the for visit 3, the 12-month follow-up visit. You had mentioned that can be done as early as 10 months. Could you clarify that?
Joe, would you like to clarify that?
Yes, Emma, thanks for the question. The intent here is to capture a range. So what we're trying to do here is allow people to come in at least 10 months or up to 15 months. We have a range of 12 minus 2 months plus 3 months, because scheduling sometimes requires flexibility. The reason why we don't allow a endpoint reeval earlier than 10 months is because we're worried it's not going to be that long-term anymore. It might be kind of still a short-term effect.
So I am curious if the practitioners have any tips to pass on about very practical things like using the iPad, entering the data in the hub system, or perhaps uploading the EDR image. Any tips on any problems that you initially encountered but solved quickly?
Hi, I want to discuss a problem. It's not about entering data to begin with. Hello, can you hear me?
Yes, we can.
My name is Dr. Imran. I'm from the South Houston area. It's not the data entry. I have a problem actually to begin with the translation part, because most of my patient population, like I would say 99% of my patient population is Hispanic and Spanish speaking, especially for 40-year and above patient pool. They cannot read or write English, even if they understand a little bit, but they cannot read or write it. So I have a trouble with that part. I could not, to the point that I could not even recruit one patient so far, you can imagine. Plus, because of the, liability is on me if a patient is taking any medicine and would ended up having any side effects or, allergic reaction to any part of the medication. All of this is very common, giving antibiotic, but the patient is hesitant to take it because part of it is like placebo, which we don't know what exactly that ingredient is. I understand that it's a nerd, but patient is having really hard time understanding that part at my end. So any advice for me, any comments about that part?
Would love to hear if any other practitioner had come across with this issue, and if you have any best practices related to that. And then I will ask Giorgio to address that. But before, would any one of you have encountered this? Because I think it's a very important issue, both of those issues.
I would say because the antibiotics, if the patients have are concerned, Dr. Imran, if they're concerned about taking antibiotics, I definitely understand, but I always tell them regarding the allergies, most of them would have taken some or the other antibiotics at least once by now. We would know if they were allergic. And according to the recent research, I think it's only 1% of the population which is actually allergic to amoxicillin. Rest of the people who say they're allergic may not be actually allergies to amoxicillin. If they're allergic, we cannot make them. They're not eligible for the study. But I will say you have to talk to them, saying that you might have already taken this medication before, and if you had never had any reaction, I don't think you will have again for this.
I'd like to assure you that everybody that is here, that we are doing this meeting today to have an idea of what are the issues on enrolling patients, because Dr. Imran, you are not alone. There are other practitioners who are also having a difficult time to enroll participants. And based on this discussion here, we are hoping that we will be learning about best practice to enroll more patients in this study. So this is a very good point that you were bringing. I would like to know if anyone here had any problems uploading the perio charts, and if you have any suggestions on how to improve that process.
Our perio charting program allows us to export the patient data onto our desktop if we want it. And then from there, I'm able to de-identify the patient right off the bat and then upload it into REDCap. So therefore, I don't have to worry about, taking a screenshot or taking a picture of the perio charting and cutting pieces out or so. So it's easier for us because we're able to export the actual data itself.
And do you have different screens for bleeding on probing and pocket depth and gingival recession?
All of those will show on the same screen.
Yes. Great. We import all that data onto one frame itself. So when we upload it, it's just one page with all the information that you need.
Great. Georgios, do you have a comment on that?
I wanted to take this opportunity to say that I know sometimes it's challenging, with different EHRs. The challenge we're seeing kind of on the back end here when we're doing the quality control of the data is that a lot of charts will have either probing depth and bleeding on probing, but not recession or attachment loss. And a lot of other charts will have probing depth and recession or attachment loss, but not bleeding on probing. So far, I think it has been very rare to see a screen that has all three of those. That's why NCC now worked on the capacity to upload multiple screens for its visit. But I would like to ask, all the practitioners here, if you are uploading something that is missing one of these three key pieces of the outcomes, just let your node coordinator know that you need a second screen if you can't figure out how to do it. It's very important for us to have that. So appreciate any extra effort that this will take to upload.
Getting to the end of our time today, it's 10 to the hour, but I would love to hear from each of our panelists if there is a practitioner who has been trained but has not enrolled the patient now. What would be the advice that you would give them? Dr. Soileau and Megan and Huong, we can start with your office.
Well, I would say that the one thing I ran into, for example, today with a patient, that's really not advice, but just an alert, a red flag that you might not have heard about or thought about, but maybe you have, is that I had a gentleman today, he had an increased furcation on an upper left molar. And normally I would do either a Reston or start him in an antibiotic, which I couldn't do it because he had already signed a bleeding study and I was trying not to interrupt that. So I thought, okay, ethically, what is right here? So we're going to see him at the 6-week reeval, and he had a cleaning today, which should hold him. So we'll see him at the 6-week reeval. And at 6 weeks, if that particular tooth is still deeper than it was 6 months ago, then we will do an arrestin at that point. And then, because I don't know if he's getting placebo or not. And then we'll do the arrestin and then see him 6 weeks after that, or a month after that, and do a re-eval that we would typically do after an arrestin or a deep cleaning. And then if that's not healed from the arrestin, then we would probably schedule surgery. So it has drawn out my regular treatment plan. It's interfered a little bit with the fact that I was trying to handle a situation where I had a kind of a hot pocket. So so I don't know if Dr. Koutsakis wants to comment on that. You know, I hope I'm not breaking protocol, but if you have a comment on that, I'm glad to hear it.
Kristi, I mean, you're absolutely right. The reality is that, you know, we don't even know if antibiotics are truly effective, right? So if today you wanted to give amoxicillin retinitis, would that really help that pocket? That's the whole intent of the study, to figure that out. So we made a choice during building the protocol of that study to go for pragmatic clinical scenarios. So your patient still would not be disqualified from the study, as long as the intervention was rendered. Although we do try to avoid, you know, any type of adjunctive treatment, sometimes it's clinical decision-making, right? Yeah.
Thank you.
Absolutely. And the real situation here is that we try to do some sort of expanded maintenance, like let's say maintenance with localized scaling root planning as needed, until the end point. And the expectation is that if the patient needs surgery, they're going to be scheduled at 12 months from baseline for that surgical procedure after having gone through, you know, 2-3 maintenance procedures as you need to. Yeah. Thank you.
Thank you, Dr. Soileau. Thank you, George. If you have any additional questions or suggestions for us and for other practitioners, please share that with our node coordinators. They are very helpful in this study, and they are also communicating with us on a regular basis, but also most importantly, they are communicating with you regularly. And that has been very helpful for us to understand what's going on in this study. Thank you very much for your participation. I would like to thank Dr. Gilbert, Dr. Koutsakis, and all the practitioners that shared their experience today with us. And as always, we always want more people joining the network. So remind them, your colleagues, when you have an opportunity to join the network. Thank you very much, everyone.